Yeah. All right. So I did my presentation on cervical disc disease, mainly focusing on injections. This is a Hurd Fang lecture series. I'm Hurd of Hurd and Fang. Alex is going to do a presentation, I think in January, on also cervical neck pain, discomfort. I was going to focus more on the disc aspect of things, and Alex, I think, is going to maybe do some facets and stuff like that. Not to steal his thunder, but brace yourselves. Applicants, please come back for Fang. All right. So this is my outline. Do a brief introduction, anatomy, some MRI images, basics on epidural injections. Then more specifically look at cervical radiculopathy due to disc disease, both an interlaminar and neuroforaminal approach, as well as axial neck pain, again with neuroforaminal and interlaminar approach, and then some injection complications, preventions, that sort of thing. So just with cervical neck and back pain, there are multiple etiologies. We have spondylosis, spondylolisthesis, disc degeneration, and disc disease with herniation, as well as systemic diseases. A lot of these processes give you headaches, and with that can be from radicular pain into the head, as well as legs and upper extremities. Some risk factors I ran across, both for disc degeneration and neck pain. I ran across aging, excessive manual labor, genetics, and motor vehicle accidents, which actually accounted for like anywhere from 25 to 70% of the cases, and according to one study. The annual incidence of radiculopathy specifically is about 83 per 100,000, and the annual prevalence is about 10 to 70% depending on the source. So the U.S. Health Burden Diseases looked from 1990 to 2010, both at the morbidity and chronic disability, which is half the U.S. burden of costs. Low back pain is number 1, neck pain is number 4. And for neck pain specifically, expenditures were in the $86 billion range. So this high level of prevalence, you can expect the interventions to have risen significantly during this time. They've seen about 140% for the transforaminal epidural injections and about 123% increase in the interlaminar epidural injections. And so it's kind of at I would say, the forefront of non-operative conservative treatment options. So a little on the anatomy. I won't belabor this too much. We'll hit the important stuff. So there's 33 vertebrae, 7 cervical. This lends itself to a semi-rigid, flexible configuration. And the discs actually make up 25% of the total height of the vertebral column, which I thought was neat. Fun fact. These are your atypical cervical vertebrae. Don't really have much of a context in my talk, but maybe Alex as well. But the typical vertebrae kind of do, more so with myself, using the transforaminal and interlaminar injections. Nothing too specific here, just review. So the intervertebral discs themselves provide strong attachments between the vertebral bodies through the annulus fibrosus and the nucleus pulposus. The discs themselves are very dynamic, flexible in nature due to their water content and their relatively increased disc thickness in the cervical spine compared to the other levels. The absolute measures of those discs in the cervical spine are smaller than the other levels, but relatively compared to the vertebral bodies themselves are actually thicker. And the nucleus pulposus is an avascular structure that gets its nutrients through diffusion, through penetrating blood vessels that go through the annulus. And the annulus itself is that outer fibrous band, concentric laminae, made of fibrocartilage that contains the nucleus pulposus. The fibers run obliquely in a crisscrossing fashion. And uniquely to the cervical spine, as the annulus wraps around into the canal, it actually becomes thin or can be incomplete in some patients. So this is be important later in the talk a little bit. We talk about complications, but just to kind of throw it in here when we're hitting anatomy, is these segmental and medullary arteries that branch off the spinal branch arterial that wrap around from the aorta. More so, that's in like the thoracic and lumbar spine. However, these are still important for any transfemoral injections because they're kind of the source of complications, is hitting these little guys. And so for the cervical injection specifically, it derives a lot of its blood flow from the ascending cervical artery, which is off the thyrocervical trunk, over here on the right, as well as the deep cervical over here that comes out of the costos cervical trunk down here. A lot of those blood supplies go in and form more vascular structures around, supply the cervical spine with its vascular flow. And those are the arteries that can be sources of complications. You got to watch out for them when you're actually doing the procedure. And so this is like a close-up picture of the same stuff. This is the transfer of a transfemoral injection at C6. You can see here, like, obviously there's the needle tip, there's the spinal nerve, and then here's a close-up picture. This is a reticular artery. It branches into like a dorsal, ventral, and they supply locally the exiting nerve roots and some of the dura. This spinal segmental artery actually goes in similar and through the neuroforamen and actually anastomosis with the anterior, posterior spinal arteries. And that's where you've heard about people having a like anterior cord syndrome as a result of a transfemoral injection because they somehow or another compromise this segmental artery vessel, and it causes ischemia to the spine. And one of the most popular segmental arteries, fun fact, the artery of Adamkowitz. Never thought I'd say that again from medical school, but it's there. So now looking at the radiology. So the 2001 Joint Task Force of these guys standardized the American nomenclature for the spine. So this is a normal radiograph of a L spine. I used the L spine just because it was so a little bit easier to see. Also, this website has some really good images, but we're just looking at the disc specifically. So they should have a diffuse hyperintensity on T2 with a central area of darkening or lower signal, which you can see with the blue arrows. And that's a normal measure. All these discs look well, healthy, good height. And axial cuts, you'll see this mildly concave posterior margin for the arrowheads. If you notice on later, we'll talk about like disc bulges, disc herniations. A lot of times with bulges, the most mild form of that, you'll actually lose that concavity, the mild posterior concavity. So degeneration is more of an umbrella term. It refers to disc desiccation, which is the loss of the water content, both angular tears, bulges, any end-plate changes, osteophytes, and then spinal degeneration can be further subdivided into spondylosis, which is a normal part of aging, as well as intervertebral osteochondrosis, which you see a lot of disc narrowing, vacuumous disc, which is the actual formation of gas, usually nitrogen, in the disc or around the spinal cord, as well as in-plate reactive changes. Here they're pointing to the loss of the disc height and the in-plate reactive changes, which is this little subtle area right here and right here. So disc bulge, this is the most common form of pathology around the disc. Basically, it's when the disc extends beyond the apophysites of the vertebral body, which is outlined on this lower left picture with this red line. As you can see, it's bulging past that. Here's the another normal just for comparison. And then here you see this broad-based disc bulge. It's actually bulging out where you lose that concavity. So now specifically disc herniation. So herniation doesn't specifically have to refer to just the nucleus pulposus. It can refer to any other cartilage, bone fragment, angular tear fragment that's in the canal. However, specifically between disc herniation and disc bulge, some people use them interchangeably. However, there's a subtle difference. With a herniation, it involves 50% or less of the circumference of the actual disc, whereas a bulge actually is more than 50%. So you can see here on this, going back, this definitely accounts for more than 50%. Then herniation can be further subdivided into a protrusion and an extrusion. So protrusion is by definition is when the base, which it exits the disc containment, the base of that is broader than any other dimension that you see here. This is a good example that actually had nice arrows. So this is the base beyond from where it's protruding, and then it's obviously larger than this height. And this is an artist rendition, and here's another longitudinal cut. So an extrusion is similar, however, the base is smaller than the part within the spine, spinal canal. So this can happen, and you can actually lose the connection here between the disc. And if that happens, it's called a sequestration or free fragment. And if you see the disc herniation that on this cut here, if it actually goes above the height, by definition, that's automatically a extrusion. No ifs, ands, or buts. You can't call it a protrusion. And if there's a mixed picture between different cuts of your spine, you can that in itself is also an extrusion. So there are these Witzel zones that localize the area of herniation. So the red line is the central, blue is subarticular, green is foraminal, yellow is extraforaminal, and gray is anterior, which is all these guys. And the little red dots refer to a paracentral location. If it has like a small left or right favor, you could say left paracentral herniation. So a little bit about injections. This is kind of the intro to that. So you have an interlaminar injection, which is an injection where you get close to the assumed site of pathology. It's great for if you have multiple pain generators, as well as it provides a shotgun approach for those multiple pain generators. The neuroforaminal epidural injection itself is a more target specific. It gives a much smaller, much more highly concentrated volume, or it can be a highly concentrated volume of drug into a certain area, and it can provide other diagnostic information. These are both used, and we'll talk about this later, for axial neck pain as well as radicular neck pain. This is just a fluoroscopy image of somebody performing a transforaminal injection. This is a cool image because it kind of outlined the anatomy over here. It's in the paper if you need to see it up close and personal. So one of the greatest papers I found was this by Cantani et al. Dr. M. We're close now. So he did a systemic review where basically he did a massive search looking for indications for both epidural steroid injections, both interlaminar and transforaminal. He ran across like 600 something articles, and he found that he narrowed them down to give evidence for both disc herniation, for discogenic neck pain, axial neck pain, and central spinal stenosis and post-surgery syndrome. For his review, he wanted pain relief 50% or more, or at least 3-point decrease on the subjective pain scale. And a secondary outcome was change in functional status. So the way he analyzed different research papers was through this Cochrane review criteria and the interventional pain management techniques, quality appraisal, and reliability and risk of biases assessment. Both of those are scoring systems. So to be considered for this, for a study, you basically had to meet a moderate quality in nature study. And higher quality is, obviously were accepted. Low qualities were not. So they found 6 abstracts and articles through their magic. They condensed it down to 7 articles that they felt were the best that they could find, and 4 which met qualifications for high quality. 3 were moderate. Of the 7, 6 were long term, over 6 months. 6 gave short term in terms of follow up, and then 7 were all of the interlaminar approach. There was none that they found that they felt met good qualifications to analyze for transforaminal. And 4 looked at disc herniation, 1 axial neck pain, 1 central spinal stenosis, and 1 post-surgery syndrome. So one of the first ones that they talked about is actually a very old study, January of 86 to 91. 24 patients. They had intolerable clinic radiculopathy, at least 3 months in length, associated with dysesthesias and a dermatomal distribution. They used a C7T1 epidural injection with loss of resistance technique. So these were blind without fluoroscopy. So they divided the patients up into 2 groups. Someone that would receive steroid and local anesthetic, and then the other group would receive steroid, local anesthetic, and morphine. They actually were monitored in the ICU for 24 hours, which I thought was kind of cool. They measured based on the visual analog scale at these time periods, both 1 day after injection and then these months. And then they called them at 18, 24, 36 to 48 months to see how they were doing. So on the bottom is a chart of the up to 1 year follow-up. And they had about over 75% success in both groups throughout their study. And actually 11 of the 24 patients had pain relief lasting 48 months, and 9 actually had pain relief lasting up to 60 months. So they're really good numbers. Stavadol, this also was an older study, also in the 90s. They had 50 patients that had chronic cervical radiculopathy for at least 6 months, either due to degenerative disc disease or cervical spondylosis. Outcome measures, they wanted to see pain relief and functional improvements. So they had 2 groups. Group A got a cervical epidural with steroid and lidocaine. Group B got steroid, lidocaine into intramuscular, and the other one's epidural. Group A was epidural. So Group A, 25 patients, they received 1 to 3 injections in a 2-week interval. They used loss of resistance technique. And then Group B, 17 patients, between 1 and 3 steroid lidocaine into these cervical paraspinals. And they just stopped the treatment once they reached, I think, 80% pain relief, and or if there was failure after the first one. And they followed up in 1 week and 1 year. So the 1 week success Group A, who received epidurals, was in the 76% range, and the 1 year success was 68%. They also noted improvement in functional scores, which they rated as range of motion of their upper extremity. Group B, who received the paraspinal steroid lidocaine injections, they had not very good results. At 35% 1 week and 1 year, only 10%. There was a statistically significant amount of improvement with Group A. These guys, they also did a prospective randomized study. This was in like the 2007, so this is much more new. The previous guys, I don't think they used much imaging techniques for their diagnosis. These guys did. They took 160 patients. Their outcomes were pain-free sleep and pain control. They divided these 160 patients up into 4 groups based on timing of onset of symptoms from acute to chronic. So the injections they did, my understanding is, they did a blind epidural injection. They used bupivacaine and methylprednisolone. They were evaluated every 4 or 5 days and would re-inject as needed. They would stop injections if they reach a pain control of over 80% for 24 to 36 hours. Then within also the other type of injection that they did, they actually did a continuous epidural infusion of bupivacaine methylprednisolone via an epidural catheter. They would use bupivacaine. They would administer that every 6 or 24 hours as needed to produce pain-free symptoms for 24 hours. Then on top of that, they would have a methylprednisolone injection every 4 to 5 days as needed. And they would continue that epidural infusion for no more than 30 days. And their pain measures were they had the patient maintain a good sleep diary and then they measured pain control. So this is pain control at 1 month and 6 month follow-up. So Group A is acute. Group D is the most chronic patients. So single, here on the left, if they received a single injection, that's a single epidural I talked about, and then the continuous is the continuous infusion. There was no differences that were seen with groups A, B, and C, which is up to pain onset up to 180 days. After 180 days, it's Group D, which you actually did see a statistically significant difference in whether they received a single epidural injection or a continuous infusion of bupivacaine and with it 4 or 5 days of steroids. Also looking then at their pain-free sleep, again, you saw this very similar results, Group A, B, and C, up to 180 days. There was no difference. After 180 days, there was a difference between similar results with pain-free sleep. The continuous infusion people had better results than the people who received a single epidural. These were statistically significant differences. They believe this difference was due to the efficacy with chronic disease and the infusion with the local anesthetic. The local anesthetic has been used in other studies to treat neuropathic pain because it temporarily will suppress the nociceptive discharge, and it will also normalize the hyperexcitability of the central neurons, and it reduces the release of neurotransmitters and reduces gene expression that results in the phenotypic changes you see with neuropathic pain. So that's kind of why they thought for chronic pain you get better results. So this is the halfway point. So this is me, Trey, and Ilya. We went chasing waterfalls despite TLC's warning not to. And we found that thing. Yeah, this was a good one. There are more later. Good halfway point. All right. So now we're talking about disc herniation. Now this is the transforaminal. So we did the interlaminar. These are the transforaminals. So Linodol, they did 70 patients. They gave the choice between surgery or receiving multiple injections for disc herniation. They monitored symptom relief, functional improvement, and the need to avoid surgery. In the success group, 44 patients had success with this. with an average pain relief after injection of 400 plus days. Of the failure group, 37%. The average relief of the injection lasted around a month. However, they were able to delay surgery for up to 200 something days. So this study was good because it showed the time-sensitive manner at which you need to perform these injections, where you get a little bit better results. So in this study, the initial time from actual consult to actually receiving the injection was around 2.5 months, which I thought was pretty long. That was kind of way too long. So the people that required surgery, of the 47% of those, they had over 100 days from initial consultation to injection. But the patients, 33% of the patients who require surgery, only 33% of them had less than 100 days, which shows that there's and these were statistically significant numbers, so it shows that there's a need to perform this injection sooner rather than later. So Dr. M, looked at discogenic pain, intralaminar approach. This study was also really good because he excluded disc herniation, spinal stenosis, spondylosis, and radiculitis. And if there was a suspected facet arthritis on top of this that could muddy up the picture, they actually performed a local anesthetic block to these and excluded patients who had a positive response to block. So he found 120 patients with chronic over 6 months functionally limiting axial neck pain due to disc disease. Their primary outcome was pain relief, improvement in functional status. Let's see. And there were two groups. Group 1 received local anesthetic only. Group 2 received local anesthetic and steroids. They had several other functional outcomes that they looked at. They looked at the Neck Disability Index and the numeric pain scale. So this is kind of hard to read, but I'll give you the synopsis. So if you look here on the baseline numbers compared to these follow-ups, you can see that they reduced by about 50% from baseline throughout their follow-ups, the scores were maintained. There was statistically significance from the baseline to these follow-up appointments, but there was no statistical difference between group 1 and group 2. And similar results were seen in the Neck Disability Index scores, where, again, their baseline scores had a significant drop. But however, when you compare the group 1 to group 2, there was no difference. Then they looked at pain medications. They looked at, again, baseline intake of opioid pain medicines. They used morphine equivalents. In group 1, there was a statistically significant difference from baseline to follow-up. However, group 2 did not experience any significant difference. So this was another, because Dr. M didn't find a study that was relevant for neuroforaminal stenosis for axial and neck pain due to disc herniation and disc disease. I found this one by Shakir and al. They localized symptoms and used MRI findings and kind of localized them to both axial and distal. They had 117 patients. They received weekly injections at the C4 to C7 nerve roots. And the way that there was multiple levels of pathology, they would just pick the greatest level, either based on symptoms and or MRI findings. And their success they defined as 70% improvement at 1 month. So this is kind of a schematic of how they divided up the patients. After they performed the injections, they divided up by their success and failure group. Then they further divided up into upper limb distribution based on if it was above the elbow or below the elbow, which is this line down here. And then they further divided up based on whether they had neuroforaminal stenosis or disc herniation as a source of their pain. So for this part of the topic, I kind of want to say axial, so I kind of just eliminated these guys. with pain below the elbow. And then I concentrated more on the disc people. So these two groups here and groups here. All right, so overall, throughout their whole study, including all the groups not eliminated by me, they had overall success in 61% and over, no, it's not percent, of 60 patients. No, that doesn't, yeah, anyway. So let's see, so looking at the neuroforaminal stenosis patients, there were 46 of them. They had success in about 50-50, and disc herniation also showed a 50-50 success rate to failure. But when you divided up a pain above the elbow, there were 25 patients with disc herniation. 60% were successful, 40% failed. And same with neuroforaminal stenosis with pain more axial. They had about 60-40 split. And these also were pain below the elbow with disc herniation. They were a little bit more successful at 69% and 31% failure. And neuroforaminal stenosis had a really good success rate here with 80-20% differences. So I also wanted to focus on injection complications with cervical epidural injections. They kind of have a rap as being this like super cowboy procedure that has a ton of complications associated with it and would scare people off from doing it. So the most catastrophic and traumatic that I found in reading was they talked about epidural puncture, epidural hematoma, infection, paralysis, and death. And the transforaminals have a significantly increased risk compared to the intralaminar. This is due to the vasculature around the neuroforamen and the needle path, which you have to take, which we saw a little earlier. So they believe these complications are due to unintentional needle cannulation of that vasculature around the neuroforamen. Also, they blame particulate steroids that were actually injected into the vasculature. And this cannulation causes an embolic infarction, or can cause embolic infarction, both in the spine itself and the brain. So there are a lot of precautions you can take, both pre-procedural and actual intra-procedural precautions. So some of the pre-procedural ones are the type of steroids you pick, whether you use, or whether you just use local anesthetic alone, and your approach angle. Also the intra-procedural precautions you can use is a flash of blood in the hub once the stylet's removed from your spinal needle. Also, if you have a negative aspiration test, which is right before you inject, you always aspirate. And then the lidocaine challenge, which is when you actually screw on your injectate solution and you just first inject lidocaine and you see if they have a positive response to that. And also use live fluoroscopy contrast. And then this new thing, digital subtraction angiography. So we'll focus on the steroids right now, whether you can use them or not. So steroids were initially chosen for the anti-inflammatory properties because they believe there was this inflammatory milieu within the spinal cord, which causes the neuropathic pain. So we want to look at both particulate and non-particulate steroids. So they surveyed the American Pain Society, and particulate steroids appear to be the primary source of complications. Methylprednisolone was the most frequently reported. Triamcinolone and betamethasone were reported in about 3 complications, and dexamethasone, which is a non-particulate steroid, was not reported. So Lee et al., they looked at 159 patients with cervical radiculopathy and root compromise. They performed this transforaminal epidural injection. They compared both particulate and non-particulate steroids. So a short-term follow-up, the particulate steroids actually had a better result. They had an improvement of 80%, and dexamethasone had about a 70% improvement. However, this was not a statistically significant difference. Then at long-term follow-up, actually triamcinolone only had 185 pain-free days within those 2 years. Dexamethasone had about 300 symptom-free days within those 2 years. And again, this was not a statistically significant number, so it kind of gives you the confidence than to use non-particulate steroids, such as dexamethasone, if you are going to use steroids. But that's another question. Dr. M. So he looked at both local anesthetics and local anesthetics plus steroids in 2 groups. I referenced this study earlier. So overall, group 1, who received only local anesthetic, and remember this is also for more chronic neck pain, I think of over 6 months. They found at 3 months and 24 months they had over 70% improvement. And group 2, who received both steroids and lidocaine, had about 70% improvement. These are their numbers. So there actually was no difference. So you might as well use lidocaine and not risk the complications that are associated with steroids for chronic neck pain. So another study we looked at is the optimal angle of entry, your angle of approach for these transforaminal injections. The goal is obviously to avoid any and all vascular structures. So your goal target where you want to put your needle is the posterior bony wall of the cervical neuroforamen. And you want to maintain a parallel relationship with that line. And if you do, you'll be posterior to any cervical nerve root and the vertebral artery. So Dr. Chen looked at 190 patients of axial CT scans from C3-4 to 7T1. And he measured the angle, this angle from midline to that your goal target of the posterior wall of the neuroforamen. And so he measured that. Let's see. So he took on each patient, he took from the 2 sides, left and right, of a single level. He averaged those numbers and then averaged all those numbers. And the average angle ranges between about 48 degrees to about 49 degrees. This was a statistically significant number when you controlled for age and sex. However, it was not clinically significant. They argue that you cannot reliably change your angle by a single degree or 2 to make a difference. So they just said the optimal angle of entry is less than 50 degrees with an overall angle of 48 degrees. So other complications that arise are from the variability of the vascular anatomy around the C-spine, most notably the ascending and deep cervical arteries, which anastomose with the vertebral artery as well as can supply the radiculomedullary arteries that are associated with the complications of transforaminal epidural steroid injections. And one study actually showed that about 30% of the vertebral arteries are actually within 2 millimeters of the posterior wall of your neuroforamen, which is kind of where you're headed. So here's our picture again. All right. So then they looked at procedural, intra-procedural precautions with your flash, your aspiration test, your lidocaine challenge, and your live fluoroscopy contrast images. And then they also, in the next study, they wanted to look at this digital subtraction angiography. And by the way, a positive lidocaine challenge test is when the patient experiences alterations in sensation, motor weakness, or an unusual metallic taste in their mouth that can be considered positive. So the way digital subtraction angiography works is it identifies first the contrast transforaminal epidural flow and subtracts out both the pre and post contrast images, and it makes the variations more evident. So this is a good example. So this actually would be your fluoroscope. This is kind of what you would see, and you can see the nice outlining there. But as you use DSA, you can see that they actually have some vascular compromise. You can see this vascular flow pattern that the subtraction angiography allows you to see. So Heyman et al., they did a cohort study. They wanted to see the reliability of the traditional methods and then see if there's any vascular penetration. They looked at both the cervical, lumbar, sacral spine, and they used this transforaminal approach. So they had 2 independent physicians observing the interventionalists performing the injections. They had 150 patients, 220 plus injections, 40 of which were in the cervical, 113 in the lumbar, and 68 in the sacral. So the way their study design worked was that they would initially use all your traditional methods first to look for signs of vascular penetration, and if they encountered any positive signs that they had vascular compromise, whether there was a blood in the hub, a positive aspiration test, lidocaine challenge, etc., then they would just reposition their needle and then go after it again. And then they wanted to eliminate all signs of vascular penetration prior to using DSA. So these were their results. So in the cervical spine, they noted only 1 flash, positive results with flash, 3 with aspiration, 7 with live flora, none with digital subtraction angiography, and similar results down here. Sacrum was the worst, with a flash seen in 10 of the 60-something injections that they did, and or 20 in the live flora. So using the traditional methods, you can feel confident about 95% that you're out of the vasculature. Flash showed about 5%, only 1 of which was in the cervical spine. Majority are in the sacrum. Then the blood aspiration tests, again, identified about 5% of the vascular compromise. Live fluoro identified about 20%. And DSA, when they added that, they identified an additional about 5% of injections. So they noted there was about 57 other procedures, 200 plus procedures they did, about 57 had vascular events, which is an incidence rate of about 25%. However, a vast majority were in the lumbar and sacral levels. So I eliminated that and looked at the cervical level only, and only about 15%, 9 total vascular events were noted in their study. And of the vascular events, they noted that all these vascular penetration was venous in nature. There was no arterial blood flow that they saw. And then I looked at, through also doing the other literature searches and reading articles, I kept track of any other reported cases of poor outcomes. And Dr. M, in one of their studies, they did some 600 plus epidural procedures. They noted 6 subarachnoid punctures, 10 intravascular penetrations, and 3 nerve root irritations without any long-term sequela. And that's it. Thanks to Dr. Weineck, Dr. Ilya. Can't go a grand rounds without making a CrossFit reference. So CrossFit, CrossFit, CrossFit. And thanks for bringing breakfast, man. It's another waterfall we chased down. Any questions?
I think it was the first or second study of the transparental part. We were talking about the exclusions. You said they excluded disc disease, disc herniations, stenosis, those others. What was the inclusion?
It was more of a axial discogenic pain. They didn't want true herniations. It was more of a axial discogenic pain, from my understanding of it. Anything else?
You mentioned a lidocaine injection prior to the transparental as a test.
Mm-hmm.
Sometimes you describe that a little bit?
Yes. So in there, what they did was they would do, so if you're doing both a steroid and lidocaine injection, they would, instead of pre-mixing the solution in both lidocaine and steroid, they would actually keep them separate. And then first do lidocaine, see if they had no reactions, which were these down here. And if they didn't have a reaction, they would just keep their needle where it is and then inject the rest of the steroid.
And so if they had that positive experience that you described there, what would
Yes, sir.
that tell you?
You're in vasculature. You need to reposition before you deliver the steroids.
Who's that?
Good question. Maybe one of the little arterioles, a venous supply. I'm not sure.
The transparental is probably going to be the tubular.
Mhm.
And that's where the catastrophic events occur with particulate. You're actually injecting a particulate larger than a red blood cell into the vertebral artery. You have little tributaries off the vertebral artery into by the spinal cord as well as the vertebral basal system, causing spinal strokes or vertebral basal strokes. So that vertebral artery versus right through the joint makes the transmetal approach that so concerning, obviously dangerous, but that's why you go through all this process that you're talking about. So that was really good to highlight all that.
Thanks. All right. Thanks.